Dear students, I hope all of you are following online classes. The virus occupying the whole world has made a turmoil in the lives of every individual, big or small. I'm sure even students like all of you are also affected in one way or other. And best thing is take it in a positive sense. When you attend classes, attend hospitals, see patients, come home and read, it is not an easy task. Now you have got all the time in the world at your disposal. I hope you make best use of your time. Read as much as possible. We are here to guide you, though in a different setup. Of course, I don't say you will be at a disadvantaged position to some extent. The practical aspect is missing, but we'll try to make up even that also in somehow, in some manner or other. So what I would advise all of you is make best use of this particular period, which is indefinite, which is prolonged, which is unexpected. Coming back to the subject proper, today I would like to deal with chronic suppurative otitis media. What is chronic suppurative otitis media? If you take the word into consideration, you will understand easily that it is nothing but suppuration of the middle ear cavity, which is long standing. And this is a condition which is very, very important from the practice point of view as well as the uh, theory point of view, because you see these cases day in and day out. It is such a prevalent disease in the society, in the community. If in India, especially in countries like India, in the rural population, you'll find as much as 45 people per 1,000. Whereas in urban population, it is 16 per 1,000. And needless to say, it is a disease of poor socio-economic group, people who don't have proper hygiene, proper education, proper nutrition, and heavily polluted environment, and all the deficiencies, vitamin deficiencies, mineral deficiencies, and proteins and other things. And one more thing is, this is a disease which is most neglected by urban as well as rural people. Even urban people, they neglect, even though they can afford to get the treatment. That is because of lack of understanding and of course lack of knowledge. It is said In good olden days, this particular disease used to give tremendous complications, which are very, very dangerous complications. We'll tell you what are all the complications. People used to die. Today, thanks for the advances, we treat these patients in time and treat them by medical and surgical means. Thanks for the antibiotics, thanks for the innovations in imaging and everything, intensive care setups, surgical techniques, anesthesiology techniques, everything put together, we have reduced the mortality and morbidity of the complications which occur as a result of the neglect of chronic suppurative arthritis media. Apart from these things, we attribute the reduction of these complications to another particular aspect, that is undergraduate teaching. We see less number of complications due to chronic suppurative arthritis media because of the introduction of the undergraduate introduction of this particular subject in undergraduate teaching. Now, when do we say that a particular patient is suffering from chronic suppurative arthritis media? The cardinal signs. What are the cardinal signs of chronic suppurative arthritis media? Discharge, deafness, and perforation. To call a particular patient suffering from chronic suppurative arthritis media, one should have these three clinical signs. Anything above will denote a complication. Suppose apart from discharge, deafness and perforation, say if you elicit tenderness in the mastoid, that means it is not a simple care. It denotes a complication. Now, broadly, this particular condition is divided into two varieties. The first and foremost variety is tubotympanic type of infection, otherwise known as mucosal type of infection. This is what is known as safe otitis media, for the simple reason that it rarely produces complications. Beware, the safe type of otitis media is not 100% safe. Next variety is aticoantral type, otherwise known as tympanomastoid type, and more recently squamosal type. This is unsafe variety of otitis media or dangerous type of otitis media. Now, before going into the details of this otitis media, let us study what are the different types of perforations we encounter in our daily practice. The first and foremost, as you see, is a central perforation. In the last class, I mentioned what is a central perforation. A central perforation is one which is surrounded by normal tympanic membrane on all sides. In other words, it is a perforation in the pars tensa. As you know very well, the tympanic membrane is divided into two portions. That is the main pars tensa, which is tightly placed, whereas the part that is above or superiorly placed is called pars flaccida, which is flaccid when compared to the other area. This striking structure, I need not say, it is the handle malleus. How do we know whether a particular tympanic membrane is right side or left side? By means of the direction of the handle of the malleus. Always malleus always handle of the malleus points towards the posterior aspect. That means this is a right tympanic membrane. Now, for the convenience sake, we draw an imaginary line along the malleus handle and another imaginary line at right angles to it at the level of the umbo. That means we have made 4 imaginary quadrants of the pars tensa: the anterosuperior, the anteroinferior, posterior and posterior-inferior. So you can see the perforation very classically in the anterosuperior quadrant. Now the next picture, again it's a central perforation because there is normal tympanic membrane throughout. It's a medium-sized perforation. Now, if you go to the other picture, you see most of the tympanic membrane is lost. This is called subtotal perforation. What is subtotal perforation? If more than 7/8 of the pars tensa is involved, then we call it as subtotal perforation. Next is, if you see, you hardly see any pars tensa. That means the entire tympanic membrane except the pars flaccida is lost. This is total perforation. And even the fibrous annulus also is destroyed. Now, these 4 types of perforations, they are associated with tubotympanic type of otitis media. As the word implies, the tubotympanic means the infection spreads from the tube into the tympanum. Tube, we mean eustachian tube. Where does eustachian tube open? Eustachian tube opens into the posterior aspect of the nose, that is into the nasopharynx, and it communicates to the with the middle ear. It's otherwise known as auditory tube or pharyngotympanic tube because it extends from the pharynx into the middle ear. Now, coming to the other 2 types of perforations. The first one is attic perforation. As you see, this is in the attic region, that is Sharpness membrane, pars flaccida. So if you find a perforation in the pars flaccida, we call it as attic perforation. The other types of perforation, this is called marginal perforation. What is a marginal perforation? A marginal perforation is one which is surrounded by normal tympanic membrane on one side and annulus tympanicus on the other side. Why do we separately study these 2 things? The attic perforation and marginal perforation, they are associated with tympanomastoid type of otitis media. That is atticoantral type of otitis media. That is dangerous type of otitis media. That is why it is mandatory. If you see a case of chronic suppurative otitis media, it is absolutely essential to know what type of perforation it is. If it is a central perforation, well, it is safe type of otitis media. If you find an attic perforation or marginal perforation, immediately it should occur. It is dangerous type of otitis media. You can see the otoscopic picture. Those were line diagrams. See, this is the malleus handle. I'm sure this must be a left tympanic membrane, and you see almost something like a big perforation, and this is the mucosa covering the promontory. And there is discharge. So, in case of tubotympanic type of otitis media, the type of perforation is a central perforation, and there should be demonstrable discharge in the ear, and also there will be deafness. Deafness is usually, it is about because of the loss of tympanic membrane and also because of certain amount of destruction of the oscicular chain. So in case of tubotympanic type of vortex media, generally you don't expect any destruction of the oscicular chain. So it is only the loss of tympanic membrane. So the hearing loss should not be very great in general circumstances. Coming to the management aspect, when somebody asks you how do you manage, management should not start with treatment, that is medical treatment, surgical treatment. Management means you should evaluate first. So how do you evaluate? First and foremost is automicroscopy. Automicroscopy is auto means ear. Microscopy is under examination. Under microscopic examination of the ear should be done. So if you see the ear under microscope, then you can see the discharge and type of perforation and other details, condition of the articular chain, etc. So once you do an automicroscopy, you can see the discharge, and first and foremost thing one should do is you send it for culture and sensitivity. You should know what type of organism is involved and what type of antibiotics that are useful for management in this case. Why you should send immediately? Because it takes time for the organism to grow and for the sensitivity to be reported, not less than 48 hours to 72 hours. So a discharge should be always sent for cultured sensitivity. Next is the pure tone audiometry. What is pure tone audiometry? Audiometry is the quantitative and qualitative analysis of the hearing loss. In our last class, my colleague must have dealt with this audiometry in detail. So before doing pure tone audiometry, one should also do tuning fork tests. By doing tuning fork tests, generally we do tuning fork tests with 512 or 256 tuning forks. By means of 512 or 256 means so many cycles per second. So if you vibrate the tuning fork and keep by the side of the ear, and after some time you transfer to the mastoid process and compare. If air conduction is better than bone conduction, it is Reni's positive. Reni's should be positive in health and nerve deafness. Reni's will be negative, that is bone conduction is better than air conduction in case of conductive deafness. Now, so the same vibrator tuning fork can be kept on the glabellum or vertex or over the shin, and you can inquire from the patient whether it is heard equal on both sides or it is lateralized to one side. If it is heard equal on both sides, it is called Weber's equivocal. If it is heard only on one side, that means Weber's is lateralized. Now Weber's is lateralized to poorer ear in case of conductive deafness, whereas in case of sensory neural deafness, it is lateralized to better ear. Now, tuning fork tests, they are quantitative and they are qualitative and semi-quantitative in measuring the hearing loss, whereas pure tone audiometry is qualitative as well as quantitative. You can know what type of hearing loss it is, and you can know what is the amount of hearing loss we are dealing with. As you all know, in pure tone audiometry, we present various frequencies, various sounds at various frequencies and loudnesses, and we'll plot a graph. And classically, you'll see air-bone gap, a gap between air conduction and bone conduction in case of conductive deafness, whereas in case of sensory neural deafness, you will have loss of both the things, both curves. That is, the air conduction as well as bone conduction will be less. Now, generally, we expect pure conductive deafness in case of chronic suppurative otitis media of tubotympanic variety. And generally, the hearing loss will not be greater than about 40 decibels. Now, further evaluation is done by taking an X-ray of the mastoids, lateral view. What does X-ray of the mastoids lateral view show? Generally, the mastoids are either cellular or sclerotic. Cellular mastoids, you can see honeycomb appearance. Now, in case of chronic suppurative otitis media, if there is mastoiditis, the honeycomb appearance will be lost. That means patient is having infection in the mastoid cavity also. Now, apart from the X-ray, we have got the latest gadgets, that is the CT scan, computerized tomogram. So the CT scan will give enormous information about the whole tympanic cavity and also the mastoid and the inner ear and so on. So this particular CT scan is more important in case of other type of otitis media, that is aticoenteral type of otitis media. It is of paramount importance. It will tell you where you are. So in general, the prognosis of chronic suppurative otitis media of tubotympanic variety is excellent. You can do, how do we treat it? Treatment is by means of oral toilet. Oral toilet can be done by two mechanisms, that is a dry mopping or a microscopic suction clearance. Previously in good olden days, they used to do what is known as wet mopping, that is gentle syringing. We rarely do it now for fear of introducing infection into the inner ear cavity. So you do either dry mopping, you take a nice sterile cotton ball and by means of our oral dressing forceps, you introduce it and gently you mop the entire discharge. For heaven's sake, never use so-called earbuds. Now, next thing is antibiotics. Antibiotics can be used either topically or systemically. So, best thing is specific antibiotics as per the culture report should be used. So, generally the organisms that are responsible for chronic suppurative otitis media are the streptococci, staphylococci, and the Pseudomonas variety, E. coli, and other things like very rarely the Moraxella, etc. Now, as per the antibiotic, as per the culture report, we give the antibiotic, that is generally the antibiotics we use topically are chloromycin, gentamicin, or ciprofloxacillin, and rarely pramycin, neomycin also. Now the systemic antibiotics which we generally prefer are the ampicillin or ampicillin clavulinate. And the third generation cephalosporin, cefixime, ceftriaxone are immense value. They have really made tremendous progress in the management of the otitis media. This, because of these antibiotics, we rarely see nowadays any sort of complication, almost never. Now, the other antibiotics which can be seen, which can be used, are the macrolide group of antibiotics, that is erythromycin or the clarithromycin or proxithromycin, etc. Now, apart from these two things, the most important aspect one should keep in mind is the cause that has precipitated this type of infection. What is the cause? The cause of this particular otitis media is tonsils and adenoids in children, and sinuses in case of adults. So these things must be treated either by medical or surgical means. Then only you can achieve a dry ear. Once the infection is controlled, then the perforation, if it is very small, it will heal automatically. If you give time, it will heal. If you control the sepsis, if you keep the ear dry, if you take enough care not to enter any water during bath, the ear will automatically become dry and it will heal. The perforation will heal. But if the perforation is of considerable size, it will not heal. It needs surgery. Surgery is myringoplasty. We have to repair the drumhead. And if the ossicles are also damaged, the ossicles are also to be repaired. That is called ossicloplasty. So either myringoplasty alone or along with ossicloplasty, the condition has to be corrected. Coming to the other variety of otitis media, that is chronic suppurative otitis media of aticoantral type, otherwise known as tympanomastoid type or squamosal type. And I have already mentioned it is unsafe variety of otitis media. And as far as this is concerned, you generally see three pathological types. First and foremost is cholesteatoma. Second is granulation tissue and osteitis. And the third variety is cholesterol granuloma. All the three pathological entities, they are associated with this type of otitis media. Now coming to the word cholesteatoma, we hear this day in and day out in the ENT department. What is cholesteatoma? In fact, the word cholesteatoma is a misnomer because the word, even though there is chole, there is no cholesterol. Even though there is oma at the end, it is not a tumor. Generally, oma will come under in all cases of tumors, a lipoma or a fibroma, carcinoma. But even though oma is there, it is not a tumor, so it's a misnomer. The better word is keratosis or epidermosis, but as a traditional uh, word, we continue to use this word cholesteatoma throughout the world. Now, what is it? What is this particular cholesteatoma? It is skin at wrong place. In simple terms, if somebody asks you what is cholesteatoma, you should say skin at wrong place. What is skin at wrong place? Now I'll give you an example. If you have a pin prick on your finger, what will happen to the pin prick? The needle has injured the surface of the skin, and due to this injury, it will carry some epithelial cells which are lining the skin medially, deeply. That means the epithelial cells which are supposed to be on the surface of the skin, they have entered deeply. They have gone into a different place. That means to a wrong place. This particular injury may result in what is known as implantation dermoid. Not in all cases, in some cases I am telling. What is implantation dermoid? In some individuals, this pinprick will lead to a swelling. That is called implantation dermoid. As the word implies, it is a dermoid, that is a cyst comprising of squamous cells secondary to implantation. Now the cholesteatoma is akin to this implantation dermoid. It is similar to the implantation dermoid. Now, how does it look like? How does cholestoma look like? It looks like this: dirty white in color with occasional glistening appearance, and it is semi-solid. What is semi-solid? Semi-solid is neither solid nor liquid, and it is foul smelling. This is the most important characteristic feature of cholestoma, and it is putty-like. Once again, putty means something very soft. Now, what are the differences between these two types of otitis media? That is tubotympanic type of otitis media, transseptal otitis media, and atticoantral type of otitis media. How do we know? First and foremost is onset. You inquire. For all medical conditions, we always rely mostly on history. So, onset of the disease is of paramount importance. How did the problem arise? Is it sudden? Is it insidious? You should know. So, in all cases of tympanic type of otitis media, patient gives history suggestive of acute suppurative otitis media. That is, patient will be giving a history of upper respiratory tract infection. Suddenly, patient developing pain in the ear. After some time, the discharge starts appearing with reduction of the pain. Very classical of acute suppurative otitis media. This history will be given in all cases of tubotympanic type of otitis media. Whereas this particular history is missing in antral type of otitis media. That is, the onset is insidious. It hardly remembers how the whole thing has started. Coming to the discharge, which I already told you, discharge is profuse in case of tubotympanic type otitis media. It is not at all foul smelling. Whereas in case of atticoantral type, the discharge is scanty and it is foul smelling. It smells like a rotten egg. Now, coming to the perforation is always central in case of tubotympanic type of otitis media, whereas it is either attic or marginal type. Coming to the type of deafness, it is always conductive in nature in tubotympanic type, whereas it is conductive generally, but sometimes there may be a sensory neural component, so it may be mixed type of hearing loss. If you take an X-ray of the mastoids, it will be cellular in case of tubotympanic type of otitis media, whereas in case of atticoantral type, it is sclerotic. That is, the mastoid is poorly pneumatized. So, cholestoma or atticoantral disease is almost always, in many occasions, it is associated with a sclerotic mastoid, poorly pneumatized mastoid. Now, last but not the least, the tubotympanic type of otitis media is safe, whereas atticoantral disease is unsafe. Now, how does the cholestoma arise? How it is being produced in the affected in the body? There are several theories. The congenital theory says there are what are known as embryonal cell rests. Generally, these embryonal cell rests, they should disappear by the time the child is born. But because of certain factors, unknown factors, these embryonal cell rests, they continue to stay in the middle ear cavity in some individuals, or in the petrous apex region, or at the cerebellopontine angle region. These three regions, they are known to uh, have these congenital embryonal cell rests. What do they contain? They contain squamous cells. You know very well, when squamous cells are there in the middle ear cavity, that means they are at the wrong place. They produce a nidus and they get keratinized, they multiply, resulting in cholestoma. So, this congenital cholecystoma is known to occur in these places. Suppose it is present in the middle ear cavity. How do we know? If you look at the middle ear cavity, the tympanic membrane, it will be sometimes the white patch of the cholecystoma can be seen through the intact tympanic membrane. The peculiarity of congenital cholecystoma is it never comes out of the middle ear. It is always inside the middle ear cavity. Very, very rarely it makes a perforation and comes out. Congenital cholecystoma, it never produces discharge. Now, in case of petrous apex, again, the cholecystoma is huge. Still, it may be asymptomatic for a very long time, and slowly it becomes symptomatic. It may produce cranial palsies or pain and so on. In the same way, the cholecystoma in the cerebellopontine angle also may be very asymptomatic, and slowly it may start symptoms, that is the cerebellar symptoms, as well as the it is in the cerebellopontine angle. This is where most of the cranial nerves they emerge. The 6th, 7th, 8th nerves, and also the lower cranial nerves, that is 10th, 11th, and 11th, 10th, and 12th nerve. They are also they are supposed to come out of this particular cerebellopontine angle, and so the symptoms of the cerebellar signs and the uh, cranial nerve signs also may be seen. If you see a CT, do a CT scan for these cases, you will have the full details. Now, this is about congenital cholecystoma. What about acquired cholecystoma? As far as the acquired cholecystoma is concerned, this is the one theory, that is theory of retraction pockets, otherwise known as Whitmack's theory. What is Whitmack's theory? Whenever there is negative pressure in the middle ear cavity, the negative pressure produces sucking of the tympanic membrane medially, producing a retraction pocket like this. So the negative pressure is mostly seen in the attic region and also in the posterior quadrant of the tympanic membrane. Why? Because these two areas, that is the epitympanum and posterior mesotympanum, they are poorly pneumatized when compared to other areas. So the retraction pockets are very, very common in these areas. Once there is a retraction pocket, this is lined by skin, isn't it? But as there is skin, the epithelial cells, they stay there. They don't migrate like other part of the tympanic membrane. So the epithelial cells, they caught here, they multiply and they keratinize, and the keratin mass is seen as uh, as a semi-solid material inside, and the squamous epithelial cells, they form the matrix, and there will be, of course, there will be granulations surrounding it, and they go on destroying the bone. Now, what about other theory? The other theory is called Rudy's theory. This is theory of hyperplasia. As per this, the basal cells which are present in the germinal layers of the skin as a result of persistent prolonged infection, they slowly they migrate. They get hyperplasia, and it will form a nidus for cholecystoma. This is theory of hyperplasia put forth by Rudy. Now, this is theory of migration. I'm sorry, this is not retraction pocket. This is theory of migration. That is, the squamous cells in the extraordinary canal, they migrate under a particular circumstance into the middle ear cavity. Once they migrate and they reach the middle ear cavity, they will not keep quiet. It will form into cholesteatoma. Generally, middle ear cavity is lined by cuboidal epithelium. The protympanium, that is the area near the eustachian tubal orifice, is lined by pseudostratified columnar epithelium, and the line, the mucosa that that is uh, that is there in the adytus and mastoid, it is flattened epithelium. Now, as far as the theory of migration is concerned, if the squamous cells migrate into middle ear cavity, it will lead to cholesteatoma. There is one more theory called Sadie's theory. What does Sadie's theory say? It is a theory of metaplasia. In case of long-standing otitis media, if suppose the otitis media is unattended, untreated, now the mucosal epithelium, that is the tuboidal epithelium, it cannot withstand that stress. So slowly it will transform into a higher grade, that is squamous epithelium. Squamous epithelium is supposed to be very, very tough. It withstands stress and strain over the skin. So there will be metaplasia, that is changed to a higher grade because of the long-standing infection. And once they become characterized, they become squamous cells, it will give rise to cholesteatoma. Now, why do we bother? Why should we care for cholesteatoma? Because it has got a peculiar character, that is destruction of the bone. How does cholesteatoma destroy bone? By means of producing certain enzymes like collagenase, acid phosphatase, and some certain proteolytic enzymes secreted by the osteoclasts and inflammatory cells that are present there. As a result of these enzymes, slowly and steadily the bone gets destroyed. Bone means, we mean the bone in the bone surrounding the middle ear cavity, that is the tegmen and the promontory and all. Apart from that, the ossicular bone also may get destroyed. Once the ossicles they get destroyed, there will be more hearing loss. And once the bone surrounding the tympanic cavity, especially the tegmen is the very thin plate of bone which separates the middle ear from the intracranium. So once the tegmen gets eroded or destroyed, the cholesteatoma will have ready access into the intracranium. That is, the infection will readily enter the intracranium and produce complications. Now, the destroyed bone, how it is being repaired by the body? It will not be repaired just like that by bone. It is repaired by granulations and polypi. What are granulations and polypi? Granulations and polypi, they are nothing but young vascular connective tissue elements. The difference between granulations and polypi is granulations are small and sessile, whereas polypi are larger and they are pedunculated. They are the result of bone destruction in the ear. The polypus in the ear is different from a polypus in the nose. A polypus in the nose is always secondary to edematous section of the mucous membrane, whereas a polypus in the ear is secondary to bone destruction. The polypi can occur near the annulus tympanicus or promontory or the facial nerve region, etc. That is why if you avulse an oral polyp, sometimes it may give rise to severe labyrinthitis and vertigo and deafness. So a polypus in the ear can never be avulsed like a polypus in the nose. Now the granulations and polypi, they are, as I said, it is young vascular connective tissue elements. That means they have got fibroblasts and also young blood vessels. They do not contain the tunica adventitia which gives strength to the vessels. That is why they readily bleed and touch. The third pathological entity that is associated with uh, aticoantral disease is cholesterol granuloma. Now, cholesterol granuloma, it does contain cholesterol crystals, unlike cholesteatoma. It is dark brown gelatinous material that is encountered in the middle ear cavity. Once there is cholesterol granuloma, the eardrum becomes dark blue or black, and the cholesterol crystals that is present in cholesterol granuloma, they are surrounded by granulations and also foreign body giant cells. How does cholesterol granuloma form? It may be because of hemorrhage and also because of the accumulated secretions. It may or may not coexist with cholesteatoma. Now, how does the patient come to you? The patient comes to you with a discharge, complaint of discharge, and of course, if you examine the patient, there is a perforation. Obviously, it is either attic perforation or a marginal perforation, and there will be deafness. The deafness will be disproportionate to the perforation because, as I already mentioned, because of the destruction of the ossicles. And patient may also have bleeding from the ear. Why bleeding occurs? Because of the presence of granulations and polypi. And we can see the retraction pocket. Either you may see an attic perforation or a retraction pocket in the attic region. You may see a perforation in the posterior superior quadrant of the tympanic membrane or a retraction pocket in the posterior superior quadrant of the tympanic membrane. When it comes to the retraction pocket, we can divide them into 4 stages. That is, stage 1, the retraction pocket will be smaller and it doesn't touch the incus. The stage 2, it will touch the incus. And in case of stage 3, there will be atelectasis, that is collapse of the tympanic membrane with the loss of incus, long process, and also the stapes. And in case of the stage 4 disease, it is chronic adhesive otitis media. That is, the entire tympanic membrane will be collapsing on the promontory. And last but not the least, in most occasions, you will find the cholesteatoma flakes in the perforation. Once again, once you see chronic suppurative otitis media of aticoantral variety, again you start investigating, send the culture for sensitivity, and also examine the patient under microscope and try to do some microscopic suction clearance. With all your efforts, you may not be able to clear the entire cholesteatoma by means of microscopic suction. Why? Because what you see is a tip of the iceberg. What you see cholesteatoma as cholesteatoma is only tip of the iceberg. The actual cholesteatoma is inside. So you will not be able to suck it out totally. And if you take an X-ray of the mastoids, you will see a sclerotic mastoid. Sometimes you may see a cavity that is produced by the cholesteatoma. And if you do hearing tests, there will be definitely hearing loss, which is disproportionate, as I already mentioned, because of the destruction of the ossicles. But there is an irony here. Sometimes, if the cholesteatoma is big enough, even though disease is quite advanced, still patient may be able to hear normally. Normally or near normal hearing may be there. Why? Because the cholesteatoma acts as a very good conducting mechanism. So the hearing loss may not be as much as expected. This is called cholesteatoma hearing. Because if you clear cholesteatoma subsequently by surgery, his hearing may be less than what it was. As patient hears well with cholesteatoma, once you remove the cholesteatoma, hearing loss may not be good enough. Now, what will happen if the condition is not treated. Patient may complain of pain. The pain may be, obviously, it is not a characteristic feature of chronic suppurative arthritis media. It denotes a complication. If there is pain in the ear, in case of chronic suppurative arthritis media of generally the atticoantral variety, it denotes a complication. That means the infection has spread beyond the level of the middle ear. It must have gone into the inner ear, or it may have gone into the mastoid, or it may have entered the intracranial. Patient may also complain of vertigo. What is vertigo? Vertigo is the false sense of orientation of the head with respect to surroundings. In short, it is the spinning sensation. So, once patient complains of vertigo means the inner ear is involved. How do we know? If you apply digital pressure or the tragus of the ear, patient starts giddy. This is called fistula sign. What is fistula sign? Digital pressure or the tragus of the ear producing reeling sensation. This is because of a fistulous communication from the middle ear to the inner ear. This is as a result of the cholesteatoma. As I mentioned, cholesteatoma destroys the bone. It may destroy the bone that covers the semicircular canal and produce a fistulous tract. So if you apply pressure or the tragus, the pressure is communicated to the inner ear gets stimulated, and patient complains of vertigo. There can be a fistula sign without actual fistula being present. That is called Henneberg sign. Henneberg sign is a characteristic feature of congenital syphilis. There won't be any fistula here, but still patient complains of vertigo. This is because of lax stapediovestibular joint. Lax stapediovestibular joint. With this distal pressure, the footplate of stapes is pushed medially, and patient complains of vertigo. Now, next is headache. Once again, headache denotes complication. The headache may be because of the persisting infection beyond the confines of the middle ear cavity. It might have gone into the infection must have gone into the meninges, or the infection has gone into the brain substance, or the infection must have gone into the mastoid at the behind the middle ear. And there may be weakness of the seventh nerve, that is the facial nerve, or there may be facial nerve paralysis. What type of facial nerve paralysis we expect? It is the lower motor neuron type of facial nerve paralysis. That means the entire half of the place will be involved. Patient will not be able to close the eye. Patient will not be able to smile. Now, there may be symptoms of raised intracranial tension. That is headache and projectile vomiting. What is projectile vomiting? Vomiting that is not preceded by nausea. And if you see the eye, you will find papilledema. These are the symptoms of raised intracranial tension. And there may be meningitis. The symptoms of meningitis, the signs of meningitis are neck rigidity and Kernig sign. What is Kernig sign? If you flex the hip and gently extend the knee joint, patient complains of pain. These two are the characteristic features of meningitis apart from headache. And there may be Gradinigo syndrome. What is Gradinigo syndrome? Gradinigo syndrome is petrositis, producing diplopia because of the involvement of the sixth nerve and deep boring pain and discharge. There may be abscess formation. The abscess formation may be a subperiosteal mastoiditis, subperiosteal mastoid abscess, or the abscess may trickle into the neck, producing what is known as a Bijol's abscess, or the abscess may occupy the zygomatic region where we call it as a lux abscess, or the abscess may be just behind the foramen for mastoid emissary vein called Settle's abscess. So these are all the complications, and the symptoms of raised intracranial tension may be because of the abscess that is present inside the brain itself, either in the cerebrum or cerebellum. In the next class, we will be dealing with the complications of this particular otitis media in detail, and I want all of you to follow carefully, and if there is any doubt, you please don't hesitate. You type it in your chat box. I'm ready to answer. Thank you.